Hello, everybody, and welcome to the IOCDF's Research Roundtable, the IOCDF live stream, where we pick an interesting topic within the OCD literature and discuss it with the folks that know it best. My name is Kyle King. I'm, I guess a rising second-year medical student now. I finished up my first year of med school like a week ago. That's pretty cool. Don't know very much yet, so don't ask me questions. Thank you, Brian. Yeah, I'm a rising second-year medical student at the Yale University School of Medicine. I research OCD. I'm an OCD advocate. But kind of more important than all of that academic stuff, someone who lives with OCD. So a lot of the things that we talk about on this show mean a lot to me and are really pertinent to my life and my family's life. This is normally the point when I say, as always, I'm joined by my co-host, John Abramowitz. But John had the audacity to take a vacation this month, which is just ridiculous. Yeah, I know. Well, I hope in Greece he feels the shame that's emanating from this live stream. But no, I hope John has a great vacation. He'll be back next month. But no worries. I have an excellent panel, and there's going to be a third panelist that's going to join soon to help get this conversation going. Today we're going to be talking about the intersection of OCD and sexual and gender minorities. I was kind of doing some background research on this topic before, and I thought a lot of the conversation was going to be on sexual orientation or gender identity OCD and that subtype. But as I started reading more, I saw that my scope of what this topic might entail was incredibly limited. So I'm excited to throw a bunch of questions to our panelists. Before I introduce them, though, I have a couple announcements that I got to make. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Second, the International OCD Foundation is not a crisis hotline. If you're in a crisis or you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988. You can also access this online at www.988lifeline.org or go to your local emergency room or call 911. Also, as many of you know, there's a comment section. We love when you put comments in there. Please put questions in there because we will try to get to as many viewer questions. There's our other guest, Andres. We'll try to get to as many viewer questions as we can as we go through. Just know that this is live, as the name live stream implies. So anything that you put in there will live on the internet forever, although we've never had any particular problems. Okay, those are all the announcements on my end. So I'm going to go ahead and start introducing our guests. Andres, as a penalty for being late, I'm going to introduce you first, which means that I'm going to throw the surprise warm-up question to you first. The other guests have the opportunity to think a little bit about it. So Andres Basilar, which I didn't get the chance to confirm. Is that how you like it pronounced?
It's Betzaler, but I never expect anyone to get that.
Betzaler. I don't know if Brian misled me. It's a semi. Andres Betzaler is a fourth-year clinical psychology doctoral candidate at Fordham University, working with Dean McKay in the Compulsions, Obsessions, and Anxiety program. Andres' primary research concerns the intersection of minoritized identities and mental health burdens, with a particular focus on OCD among sexual minority populations. He is additionally interested in novel ways to augment treatment, as usual for OCD, through digital intervention. So, Andres, in one sentence, what was your favorite grade while going through school and why?
Oh, that's a good question. Okay, and I feel very on the spot. Cool.
Yeah.
I would say seventh grade. I think there was something very like collective about how it was like everyone was like going through something or struggle, but it felt bonding. And like I also remember going on a really fun camping trip as part of my school seventh grade. So I feel like that was like bonding.
Okay, I feel like I was not expecting you or anyone to say middle school. I definitely didn't have a good time in seventh grade, but I'm glad someone had a good time because of how terrible it was. Yeah, so anyway, now Caitlin and Brian, you have a sense of what question may be coming. Although I feel like maybe in future streams I should switch it up so that no one ever knows what's going to come. But I won't do it this time. Second, I'll introduce our guest, Dr. Caitlin Pinciotti. Dr. Pinciotti is a licensed clinical psychologist and assistant professor in the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine. She serves as co-chair of the ICDF Trauma and PTSD and OCD Special Interest Group. Parentheses, she's also come and talked to my special interest group about the intersection of PTSD and OCD, and she's phenomenal. If anyone wants to hire her as a speaker, I don't know if you're open to business, but Dr. Pinciotti's research focuses on the assessment, conceptualization, and treatment of OCD, trauma, and PTSD, and she has a secondary interest in identifying and correcting mental health and treatment inequities in the LGBTQIA+ community. She's published over 70 peer-reviewed articles and book chapters on these topics. Dr. Pinciotti, same question goes to you. Favorite grade and a sentence why?
Yes, I think I would have to say my senior year of high school.
That's a more normal answer, Andres.
I went to an all-girls Catholic school, and for anyone on the live stream who has that same experience, you know how fun it can be with getting in trouble in a way that's not really getting in trouble. And so definitely by senior year, I was a known suspect, and in place of detentions, they sort of just like started just giving me jobs because the detentions weren't working. So
okay. The punishment wasn't good enough.
Yeah.
Okay. When you said all girls Catholic school, I was thinking the story was going to go in a different direction, maybe. But I'm glad you had a good final year.
Yes. Yeah. Well, you have to do a lot more to get in trouble in a public school, but in a Catholic school, I mean, the things that we did were really very silly. So then it was very reinforcing.
The things I did in public high school and senior year then probably would have gotten me expelled immediately.
Yes, exactly.
Our final guest, Dr. Brian Feinstein, is an associate professor in the Department of Psychology at Rosalind Franklin University of Medicine and Science. His research focuses on understanding and addressing the health disparities affecting sexual and gender minority populations, especially bisexual, pansexual, and queer bi+ individuals. In particular, his work focuses on understanding how different types of stress, like discrimination, internalized stigma, or rejection sensitivity, influence mental health and substance use, and developing and testing interventions to improve the health in sexual and gender minority populations. He is also an associate editor for the journals of Psychology of Sexual Orientation and Gender Diversity and Behavior Theory. Okay, I just got a notification on Google Docs. I went offline for a second. Everyone can still see me?
Yes.
All right, cool. So Brian, same question to you. Favorite grade? Don't pick something as random as Andres, but don't pick something as basic as Caitlin.
Yeah, well, first, I'm shocked. I definitely would not pick middle school or high school. Both were pretty terrible experiences. I'm going to go with fourth grade. I just had moved to a new state. So on the one hand, that wasn't great, but I happened to have a teacher who was like really into field trips, like more than anything I've ever heard from anyone else. So I think we went on field trips at least once every 2 weeks. Like we were just constantly, like multiple times a month for the whole year. We were just constantly going like out to different places. So it was a lot of fun getting out of the classroom and doing a lot of field trips, much more so than I think like most elementary school students are doing.
Yeah, I always had a lingering suspicion that when I went on a field trip in elementary school, it's because my teacher couldn't figure out what to do that day. Anyway, that may be a trick of the trade. So before we eat up too much time talking about whatever, because I could go on about random topics forever, I want to start kind of centering this conversation around some general questions. So I guess where I wanted to start, I guess let's start with some definitions. When I say sexual minority or gender minority, what exactly am I referring to? And this kind of goes to anyone.
Yeah, I can take that. I mean, I think for me, I'm thinking about kind of the whole entire LGBTQIA+ community. So people who essentially have any sexual orientation that is other than heterosexual. So in some group that is minoritized or marginalized in some way, or folks with a gender identity that is
transgender, non-binary, or anything that is not cisgender.
And like, what percent of the aggregate population in the US and the world would identify within those communities?
That's actually like kind of a hard question to answer. I feel like it depends a lot on age and a number of other factors. So like a pretty common statistic, at least for sexual orientation, is that like about 10% of the adult population in the US is lesbian, gay, bisexual, you know, any sort of like sexual minority identity. That said, as we've seen in recent years, we're seeing numbers that go all the way up to more like 25% when we're looking at adolescents, where we see pretty dramatic spikes in recent years in the percent of people who identify as sexual minorities. Off the top of my head, for trans and non-binary folks, I feel like statistics typically hover around like 0.5% up to sometimes in like high school aged youth, you see up to like 2%. That said, there's not as much good data in terms of like tracking like the US population with respect to genders that are, you know, trans or non-binary or anything like that. So the data there are a little bit more limited.
Okay. So I know kind of, at least thrown around in the OCD research world, it's like, you know, 1 to 3% of folks have OCD. What are rates of OCD like in sexual minorities and in gender identity minority populations?
I can maybe speak to the sexual orientation component. I think similar to Brian's answer, which is like the worst way to answer a question, is that I think it's complicated because like methodologically we haven't really explored like sexual orientation correctly. At least like historically we haven't really asked the right questions, if we asked the questions at all. So I'm prefacing what I'm about to say with that, but they appear to be, I mean, rates of sexual minority identity are higher across every condition, every disorder, every group of cluster of symptoms. But I think Caitlin and I have, and Brian too, have kind of identified that there is this like elevated risk in OCD for sexual minority folks. So data coming from like a residential treatment facility, so maybe one step up from outpatient providers for OCD, we found that like in 2023, this is a really high. So I'm positioning this as like the highest I've seen was like 36%. I think on average it's more like 15%, but regardless.
36% of folks with OCD identified as being a sexual minority, or the other way around?
Yeah, you're right. I said that in a confusing way. So out of the residential sample, 36% were not heterosexual. So had another sexual orientation besides heterosexual. That was 1 year. I think more average, we find like 15 to 22%. But I think regardless of like the exact number, there's clearly a higher rate of sexual minority people, at least in that treatment context. I can't speak to like outpatient, but at least in like partial hospital residential treatment, that's what we're seeing.
And Caitlin, do you want to?
Yeah, you did a great job summarizing that. And I think, Andres, didn't you have a paper where you looked at sort of the trajectory over time and sexual minority identification within intensive programs has been increasing over time too, which is sort of mirrors, you know, what's happening in the general population as well.
Andres, brag about your research. Come on.
Gender minority, there's a lot less research done on it. There was one paper where it was an undergraduate sample, and they looked at the rates across like a range of different psychiatric disorders and how often people had been diagnosed with or treated for them in the last 12 months. And I would want to say, and both of you correct me if I'm misquoting this, that they found sort of the general population of undergraduates, it was like maybe 1 or 2% for OCD. But for gender minority students, I think it was 9%, 7 or 9, something like that. So either way, in both groups, we don't, I think, feel like we have a great number to pin down quite yet. But what we have seen is that there's a greater proportion of sexual and gender minority individuals with OCD than what you would expect in sort of the general population.
Yeah. And I have kind of two lines of questioning that pop up from that, or three rather. But I want to bracket the current data and get back to something you said, Andres. Could you give like a little history of why methodologically we've been so bad at collecting this information, and why all three of you have to hedge so much when giving these statistics?
That's a good question. I think people who are in, like, historically who have held power and who have been in charge of research and research programming, this isn't just for OCD research. I think this is like broad across the field of psychology, haven't prioritized or tried to understand experiences from marginalized individuals. And so I think that when you look at most studies that have like established, let's say, for example, ERP for OCD, like I think Monica Williams published something in like 2010 and 2015. There's like absolutely like zero marginalized racial individuals, and then that carries over also for other marginalized identities. So like they just weren't, like, the questions were not being asked because at the time I don't think it was prioritized, at least by those in charge of research at the time. I don't want to like blanket that too much because I'm sure there were individuals working really hard, but over the research, we just haven't seen those questions being asked. And then when they are asked, what we often get are sort of these like generic broad umbrella categories of like, are you LGBTQ? Yes or no? And so I think part of our line of research is we understand that there are differences. It's a large umbrella term, and there are differences within subgroups and things like that, like Brian's work with bi+ individuals has shown us. So I think that now we're trying to get more fine-grained about how do you identify, and leaving it open box too, so folks can more like personally answer that question.
Yeah.
We're hedging is because I think we're relying on like 3 papers, and those 3 papers are like, one's me, one's Caitlin, and one's like another group. So I'm like very, very cautious about interpreting my results beyond the limited findings that we've had.
I was reading a little bit about this before, and I was like, like all of these papers are written by guests, which I guess is really good in talking to the right people. But it did seem like, this is a very emerging field, if you will. Brian, or your name was invoked. I don't know if you're the best person on the panel to answer this question, but like in that data that Andres mentioned, where you see, 33% of folks in this, I think you said a residential program, identify as a sexual minority. Is that like, can we parse that out and say, oh, well, what slice of the sexual minority are you part of, I suppose? Are you bi+? Are you gay?
Yeah, Andreas, let me know if I'm remembering this wrong, but I'm pretty sure that we found that like the majority, or like the largest group within that, was bisexual people, so that they were definitely like overrepresented even within that kind of 33-ish% of that patient population, which is what we generally see across the board when it comes to mental health, that we see that people who are bisexual or who use another identity to like label to describe attraction to more than one gender, like pansexual, queer, fluid, generally they tend to have higher rates of pretty much most mental health conditions, depression, anxiety, OCD, etc. So, well, there's not as much research, sorry, on OCD, but a little bit suggesting that they might. So kind of generally pretty consistent with what we see across the board.
And yeah, speaking of other conditions, like, I know you said we haven't done a lot of work in OCD, but does it seem like the evidence we have for OCD, there's a OCD is disproportionately worse in sexual minorities versus sexual minorities and depression, or sexual minorities and PTSD?
Yeah, that's a good question. I would say probably not. I think like generally, I feel like a good like rough statistic is like we usually see about 2 times the rate of like most types of mental health problems in at least like sexual minority populations compared to heterosexual populations. So I don't know that there's something like especially unique about OCD in that way, as opposed to just sort of any depression, anxiety type disorder.
Okay. Caitlin, I feel like this is going to be a question for you, or it's an unanswerable question, or maybe both. Why might it be the case that people who identify as a sexual minority or a gender identity minority tend to have higher rates of these mental illnesses?
Yeah, that's a great question. You know, if you think about sort of the general population and the experience of being human, we all carry with us like different risks for things, right? Like you may have a sort of genetic vulnerability if you have a family member who has OCD. You might experience stressors or trauma, which is what a lot of my research is on, and that might sort of increase your risk for OCD. And that's true of all of us. And then sexual and gender minority individuals in particular also experience, on top of that, these unique experiences related to their sexual or gender identity that sort of compound all of these stressors and risk factors. And that's why we think that people, sexual and gender minority people, are then more likely to struggle with these various mental health concerns. And minority stress is a term for kind of identity-based stressors. They can be stressors that are sort of external, like out in the world, discrimination, harassment, violence, things of that nature, being rejected by other people, which then become kind of internalized. So people then internalize messages about themselves. They may become really, sensitive or sort of expecting being rejected by other people. They may feel like they have to conceal their identity. So you can imagine sort of the burden of juggling all of that on top of just sort of everyday like human experiences.
Brian?
Yeah, I'll just add a couple things or emphasize a couple kind of pieces of that also. I think the first which certainly Caitlin kind of described in what she was saying, but just to make it like super explicit, we don't think there's anything about being LGBTQ specifically that contributes to having, an increased risk for something like OCD. That we really think it's about these sort of like external factors, things like stress, trauma, discrimination, etc., that this group just tends to experience more of, and that is why. The other thing I'll add is like, we do think of a piece of this puzzle are these kind of unique types of stress that are based on someone's identity. But in addition to that, even just kind of the general stuff that Caitlin mentioned, like, anyone can be exposed to trauma. Anyone can be exposed to sort of like other types of stress that aren't about who you are. And we also see that LGBTQ plus people have higher rates of those things in general too. So it's kind of this like combination of the stuff that everyone experiences. LGBTQ plus people tend to experience that more, like the stress and trauma. Plus, there's these like unique stressors and unique types of trauma that are really like rooted in or connected to their identities that kind of like interact with each other in a sense.
Why is it the case that LGBTQ individuals experience the kind of normal everyday traumas more?
Well, I was looking at Caitlin, not that she can see me looking at her because she does so much trauma work. I think I'll say in general, like part of it is that, we often don't know why someone, especially if we're thinking about sort of like interpersonal types of trauma, we often don't know why exactly somebody is being targeted or victimized in some sort of way. They might not even know. So maybe a caveat to what I said about sort of like the general, not even related to their identity types of trauma.
Yeah, it could
a lot
be,
of the time, we might not even know. So like there could be some sort of connection that is just often not super explicit.
Okay. Caitlin, I don't know if you have anything to add.
No, that was great. When you asked it, I sort of paused, like, wow, that's a like a really big question. So yeah, thanks for taking that one, Brian.
That's kind of my thing. I ask questions that are impossible to answer and then expect you guys to answer it in like maybe a minute and a half. Okay, so I guess like why would it be the case if I'm understanding this correctly, like there's kind of repeated traumas related to identity that then like get thrown into the black box of the human mind and then end up kind of manifesting in a mental illness. Is that right? Okay. Why OCD then? Like, how does it end up going through the black box and ending up as OCD? Because it seems like disconnected to me.
Yeah. I think we just don't have the research yet to answer that question, because that's also sort of a larger question, kind of regardless of sexual orientation or gender identity. Like, why does this person develop depression and this person develops OCD? And we can't really pinpoint that quite yet. I imagine that it's some sort of combination of all of those things. I think, again, genetics can, there's this model called the diathesis stress model, which is like overly wordy to mean that basically we all are sort of born with some kind of baseline level of risk for different mental health concerns. And sort of the addition of the environment, trauma, stressors, upbringing, those sorts of things can sort of like push us over the edge to then sort of meet criteria for say, a psychiatric disorder. And so if you're sort of from day one already at a really high level of risk, say you have a sibling or a parent who has OCD or whatever condition you're looking at, then it's not really going to take a whole lot more from the environment to sort of like move you into that kind of clinical space. And then the reverse is true too, right? Like there's some people
even if you're at a lower level of risk, more,
yeah.
And is it kind of important within this model that there be repeated incidents of trauma and like microaggressions perhaps, or like, or macroaggressions? I don't know if that's a term. Is that like count the same towards, pushing someone above a threshold in this theoretical model?
There is research not specific to sexual and gender minority people that repeated trauma exposure increases risk for OCD. So like each subsequent time that someone experiences a traumatic event, their risk for developing OCD increases.
Wow.
Which maybe seems like an obvious statement about mental health in general, but that's actually not true of many disorders. So
really?
There is this kind of, what's that?
Which ones? I would assume that applied broadly, but I guess it doesn't.
In this one study, it was only OCD and panic disorder.
Wow, that's really neat.
Yeah. And so there's definitely this unique impact of trauma on OCD, which is why I love researching that and treating that so much. And yeah, that can sort of just snowball a little bit.
I was going to add too, like if we think about how we conceptualize like mental health disorders, oftentimes we have like, you meet criteria for, let's say for OCD, for example, it's sort of like binary, like you meet criteria or you don't. But I think more research is sort of showing evidence along this sort of model of like, we all do things at times that you could categorize as like OCD-like symptoms, like checking, or we have intrusive thoughts or thoughts or images or things that kind of pop up and then don't go away or things like that. And so the idea is if we're all sort of experiencing that, but to like different levels and more on this continuum, I don't know, I was just using that as like an OCD specific example of how you could see how increased stress or like some beliefs that you have about your thoughts, how that could quickly sort of start to snowball into developing more symptoms and more impairment and things like that.
Yeah, Brian?
Sorry, one more thing. I was going to jump in. I'm glad, Andreas, that you brought up sort of some of the beliefs that people have. We might be talking more about this later, but some of the work that Caitlin and I have been doing more recently has been looking at some of these sort of general beliefs that we know are implicated in OCD. So I think like this is just one of many potential examples, but like one more specific OCD example is like when people experience, stress or discrimination, if that can contribute to certain general beliefs that we know kind of fuel OCD symptoms. So like an overinflated kind of responsibility for harm, feeling like you are like, what you do. And if you engage in certain behavior or don't engage in certain behavior, that is going to kind of, have implications for, are you protecting other people? Are you protecting yourself? So there are some ways in which some of these sort of like stressors and discrimination we think can kind of like contribute to OCD symptoms through some of the kind of general beliefs that for a long time have been implicated in OCD.
Mm-hmm. Okay. So like there might be kind of a more direct link you can draw to kind of like these general constructs that contribute to OCD more broadly. This kind of theory or this idea that you all have kind of contributed to that this conversation of these stressors pushing someone towards a threshold of then meeting this criteria that we have. It's of course not, I don't think at least it would apply only to sexual minorities. I think it would apply to racial minorities or ethnic minorities as well. Is that a correct assumption on my end? And does it seem to affect sexual minorities at a particularly higher rate, like than other racial minorities, or rather just racial minorities or ethnic minorities? Or does kind of this model seem to apply broadly and there's no differences between minority groups?
There haven't been any direct head-to-head comparisons. So it's hard to speak from that standpoint, but Andreas mentioned a little bit ago, Monica Williams has done some research on OCD and OCD symptoms in the Black community. And they have found that more experiences with race-based discrimination was associated with more severe OCD symptoms, both when you look at folks who have OCD, as well as when you just look at folks who don't have OCD, but have those sort of like subclinical obsessive compulsive symptoms. And there's even been some kind of like experimental research where they can sort of prime people to be thinking about certain stereotypes or discriminatory experiences, and then that can sort of in the moment inflate obsessive compulsive symptoms. Specifically, they were finding a lot with contamination concerns in that group. So, I think there's sort of these like two separate but quite small literature bases that are sort of parallel, but they haven't really intersected yet, which is a huge gap.
One thing I'll add too is that there's like one paper by one of our colleagues, Lauren Wadsworth, and it looks at basically like how it's basically like a tick mark of like how many minoritized identities an individual holds. So thinking about like your gender identity, your racial identity, your ethnic identity, ability status, socioeconomic status, like all those kinds of identities. And she found that the more marginalized identities one holds, the more severe their OCD symptom severity was, and their like lower quality of life pre-treatment, and then also their outcomes were worse. So I don't know if that directly answers your question, but I think it speaks to the fact that there's sort of, it's not just sexual minoritized individuals who are minoritized based off their sexual orientation. It's really a broad kind of pattern we're seeing.
And I kind of wanted to ask that question too, to get at a point that Brian made earlier, that this isn't something like inherent to LGBTQIA plus individuals. This is something that like is because of environmental factors contributing or acting upon them, I suppose. You mentioned subtypes or symptoms, Andres. So I want to pivot the conversation now to kind of the natural question that I had when I read that our subject is going to be OCD and LGBTQIA plus. Is there kind of symptoms, compulsions, obsessions that you see more often in sexual minority populations, or not?
Caitlin, this is you. I'm not. This is your. Not stepping on any toes.
No, that's fine. I'm sure that you could talk about it perfectly fine. So I've published a few papers on this, and it's a little bit interesting. So the first paper that I ever published on this topic, we did find, and this was undergrads who had clinically elevated OC symptoms, so not necessarily with a diagnosis, but potentially. And we found that sexual minority undergrads endorsed more severe unacceptable thoughts. So, thoughts related to harm and religion and sexually intrusive thoughts and those sorts of things, more so than the heterosexual students. I've since tried to replicate that twice in two clinical samples, one which is published and one that we're working on publishing with a Latin American sample, and it has not replicated when you actually sort of isolate people with OCD. Wow. There was one paper that I published on gender minority individuals, and that one did find that there were more severe, I should say gender minority individuals with OCD, so diagnosed, that they did have more severe contamination symptoms compared to cis men. but it was a really, really small sample size. And so, you know, it's sort of like, maybe there's a pattern here, but we need to keep looking into it.
Something I'll add too is that, and I think this complicates the picture even more, is that we did a research study looking at like beliefs that individuals hold. And there are certain beliefs, like we were saying earlier, that might lead an individual to maybe be more susceptible or more likely to carry certain symptom profiles. And we found that sexual minority individuals have like more severe symptoms that are related to these obsessive beliefs. However, that didn't necessarily mean that the symptom profiles were different. So I don't know if it's like a measurement or assessment issue. I'm not sure exactly what it is, but it's just not clear, at least from like the outside, what people are presenting with symptom wise, if it's different or not. Like there's mixed evidence, like Caitlin was saying, but then there are also these like differences with like these beliefs individuals hold, but it doesn't come forward as symptoms. So I think it's a very complicated picture that we don't know a lot about.
Yeah. Wait, can you re-explain what you just said, Andres? It was
yeah, sorry. So I know, and I'm trying not to get
no,
too,
it's like, not you, it's me.
I'm also trying not to get too in the weeds because I think I don't want to like overestimate our findings, but basically they're beliefs that we would conceptualize as sort of like dysfunctional or unhelpful to individuals with OCD that we think are relevant to their development of OCD. So for example, I think like the idea that if I don't do something perfectly, it's not worth doing at all. So that's like an obsessive belief that an individual might hold. And then if you hold that belief, you might be more likely to have, you know, symptoms around perfectionism, because as things come up in your life, you might have the thought, what if I didn't do that right? I'm going to recheck it. Or I need to check, or I need to make sure that I do things perfectly so that I don't know.
So I think you're saying sexual minorities maybe don't have the end result of perfectionism at any different rate, but they more strongly hold maybe that core obsession related to the end result.
Yeah, exactly. Yeah, like the belief it was only actually found between bi+ individuals compared to heterosexual individuals. But bi+ individuals in treatment with OCD did have this higher belief. And I think that this is like burgeoning, but we think that the beliefs are likely potentially like Brian was kind of alluding to, are related to these differential outcomes. I don't know. I'm kind of speaking now like top of mind. So
well, if I could jump in here, because there's a lot of parallels with this and the OCD trauma intersection space. Because I've done similar research where I've looked to see, are there certain symptom profiles that are more common among people who've experienced trauma or people who've experienced certain kinds of trauma. And I think in both cases, what it comes down to is it's more about how someone experiences and is impacted by and makes sense of the trauma or the minority stress, like the experiences that they have. We're all unique in that way. And so it's less about, you know, if you experience this or if you have this identity, you're going to have this symptom, and more this experience, this identity can intersect with previously held beliefs you have or the values that you have, and all of those things sort of work together to then like, okay, now this person struggles with contamination or this person struggles with just right. So I think what Andreas is speaking to is more like, even though we don't see consistently these differences in symptoms across all people with these identities, there are these sort of underlying processes at play, like the way that these experiences impact someone's beliefs about themselves, their core fears and things like that, that then can manifest in different things.
But yeah, again, it points to kind of how you were saying, Caitlin, it depends on how the individual integrates the fluctuating severity of these beliefs, which are again influenced by these broader environmental factors.
Exactly.
What do you make kind of this mixed evidence about symptom presentation? And like, you know, in one cohort, you see that there is a statistically significant increase in X symptom amongst sexual minorities, and then in the next sample, you don't.
Yeah, I mean, I think it speaks one thing to the complexity of humans. You know, it's like just when you think you've maybe figured something out, you really haven't. And that's why in research, we really need replication studies. We need studies that try to answer the question again in a different sample or in a different way, like Andreas pointed to, like potentially there's something with our measurements that we're using that aren't quite getting at these nuanced experiences of sexual and gender minority individuals. And so I think for one, it speaks to how science can move sort of slowly and needs to kind of build upon itself, and we can't just rest on this one study found this one thing. I think the other piece too is, you know, we may find some of these differences at lower levels of OC severity. And then when you get into a clinical sample, like a lot of the research that I did early on was with the Rogers behavioral health sample. So these are folks who are in, you know, intensive residential treatment. Everyone has really severe OCD. So it's going to be harder to find those like differences across these different groups because everyone is really struggling. There's less like room for differences across groups.
Okay. I think I know what you mean. But you mentioned Rogers, and that brought up another question in my head. Are there treatment outcome differences between? No?
No, and yeah, Andres, why don't you take this one?
No, go ahead. I didn't mean to interrupt you.
Well, I think Andres and I both have done some research where we've looked into that and found that there are no treatment outcomes differences with sexual minority individuals compared to heterosexual individuals. Again, in the one paper that I published on gender minority individuals with OCD, we did find that there was a difference in treatment outcomes. Gender minority individuals in that sample had longer lengths of treatment stay. Again, this is like an intensive treatment. So length of stay is really sort of the main indicator of outcomes. And they also did not significantly improve in, I think it was their contamination and just right symptoms. But again, it was a sample of, I think, 17 people. And so we really need to try, like there could just be something different about that data or that particular cohort. So we really need to keep looking at that and seeing if that's a sort of true effect or if that was something just random in that sample.
And you said that's for gender identity minorities? Okay. But then sexual minorities, there doesn't seem to be any differences in treatment outcome. And have there been kind of large studies to give me confidence in that conclusion?
I would say large enough and across different treatment programs have found the same thing. So Andreas and I have both separately found that in 2 different treatment programs, which also sort of inspires a little bit more confidence.
Mm-hmm. The only thing I'll add as a caveat is that I think the word, without getting too nitty gritty, like outcomes, I think also means different things to different people.
Yeah.
And the one thing we did find was that like rates of change differed a little bit with like certain constructs. So for example, like how much better people's quality of life got in treatment was actually, we found like a difference between like gay and lesbian people, between heterosexual people, where both are getting their quality of life is both improving. So like, if you look at it from just purely like beginning point and end point, you would say like, great, no problem here. But like recently we did we used like more time points and tried to find like averages of like change. And what we found was that the rate of change was like a little bit different. But again, folks are still ending with much better, much higher quality of life for that specific example. And then the other thing that me and Brian are working on now has found that there might be a treatment outcome difference for PTSD severity for individuals in treatment for OCD. But we're sort of working on that a little bit. But that's really the exception. Like Caitlin was saying, we're mostly finding no differences, couching that for sexual orientation, not for gender identity.
Okay. And as it relates to that rate of change, just because I don't think I heard you say it, what was the rate of change difference?
Yeah, so monosexual, like gay and lesbian individuals were increasing their quality of life at a slower rate than heterosexual individuals. So that like, I wish I could show, I'm like such a visual person, it's hard to describe, but if you think about like, they're getting like this much happier, and then gay and lesbian people are getting like this much happier. So it's like a difference in sort of the rate of change across treatment.
You're talking about that y equals mx plus b stuff. I know that.
Exactly. You got me.
I took algebra. Okay. That's I suppose it's just one cohort, one study, but is there a sense to why? My natural inclination is to always ask why, and I feel like it's hard to speculate with the limited data.
I think it's great you're asking why. I need to do that more. I'm like, okay, that's enough. And I, again, have like a really bad answer in that, like, we actually have absolutely no idea. And that was really preliminary evidence that I wouldn't use to dictate anything about like how to augment treatment or implement anything unique. Like, it was really just felt like more of like a signal. I don't know, Brian, if you have more of thoughts on how to,
Yeah, and maybe just to first sort of like kind of summarize, I think, some of what you said and maybe expand on it. So like generally what we're seeing is like not necessarily with OCD, but some of these other like secondary outcomes, we're seeing more differences in these treatment outcomes between groups. Mm-hmm. So we've been looking at, like a population of people in like inpatient or like, intensive outpatient care or residential at times care specifically or like primarily for OCD. And maybe not surprisingly, like outcomes, at least for sexual minorities and heterosexual people, aren't different there because that's really what the treatment is like primarily focused on. But hopefully with good treatment before people are leaving, you're seeing sort of similar, lower levels of symptomatology. But for some reason, we are seeing some of these differences in like, we've seen also that like bisexual people having like higher levels of depression all throughout treatment compared to other sexual orientation groups. We're starting to see that maybe, I think some differences in PTSD symptoms, Andreas, also. So like something's, same trend. So like something's kind of going on with some of these groups on these like non-focus, the symptoms that aren't the primary focus of treatment. I think what I'll say in terms of what is going on is like one of the things that's so hard to know is like we know so little about what is actually going on in treatment. What are the interactions like between, clients or patients and providers? Are people disclosing their sexual orientation or gender identity to their, different people on their treatment team? How are people reacting to this? If somebody is in sort of like a residential or like a longer term care program, like what are their interactions like with other, other patients receiving care in that environment? So I think like an important next step that, I would say, I think we're hoping or would love to go in that direction is really trying to collect more information on like what is actually going on when people are in treatment to really understand how that's playing a role in people's outcomes in treatment. And I'll say that is quite challenging because there are a number of difficulties in sort of like being able to collect that kind of information when people are in care.
Yeah, certainly. That kind of leads perfectly into the next sort of question that I wanted to ask. But before I do that, let me read this question. Arye, I hope I pronounced that okay, just asked, could there be any differences in OCD incidence between people who had to spend portions of their lives hiding their gender or sexual identity versus those who have been able to live more openly? That's a good question.
Yeah, that's a great question. There absolutely could be. I don't believe there's been any research that has directly addressed that. There has been some sort of like parallel research that has found generally that like people who sort of are quote unquote in the closet for a longer period of time and like don't come out until later have higher depression than those who kind of come out quicker and spend less time kind of hiding their identity or keeping their identity from other people. So, we generally think of like that time of like not disclosing your identity to people as often a really stressful experience for people. So I think it would stand to reason that I wouldn't be surprised if we found kind of what Arye is, asking and suggesting potentially, but we don't actually know.
Yeah, I assumed it was too detailed of a question potentially. I want to switch gears to treatment, and because we don't have too much time, I kind of want to throw this to Caitlin specifically. My broad question is, does treatment change for folks with a sexual or who identifies as a sexual minority? And then I want to throw this to Caitlin because I saw that you've done some work on, I wrote this down, justice-focused treatment, which is a term that I had never heard before. So, Caitlin, if you wouldn't mind taking the broad question of does treatment change, and then make sure to hit on justice-focused treatment.
Yeah, sure. I think the broader answer is yes and no. I think, which I know you love, we just keep like,
this whole panel has just been not helpful.
So I think to the extent that it doesn't change is we know that ERP works. There's no evidence to suggest that ERP is less effective for sexual or gender minority individuals. And that's really good. That's a good thing. I'm glad that we keep finding that with respect to OCD symptoms. And so there isn't anything kind of fundamentally different. We don't have data at this point to suggest that we need to change anything fundamental about how we do ERP. Now, sort of the yes part is more so kind of the nuance of because we know, and we have some emerging data that's coming out on this that I'm excited about, that sexual and gender minority individuals can sort of report on these unique ways that they feel like their OCD symptoms intersect with their identity, with their minority stress experiences. And there's kind of these common themes that have emerged there. I think as clinicians treating the whole person, we would be remiss not to consider those intersections. If someone has developed a core fear about themselves, that they are, disgusting because they're trans, and then we just, sort of treat their surface level contamination fears and don't ever address that there's this association with this internalized stigma they have about their trans identity, we're really only treating sort of a portion of what's going on for this person. And so, this is where, again, the research is really emerging. So I don't have like a study where I could say, when we did it this way, we found this outcome per se, but from my clinical experience and my research experience, I think there are these really important intersections that impact how people show up to treatment, how their symptoms present, and what keeps them really stuck. And, as clinicians, it's on us to understand the full picture of what's going on with someone.
So if I'm a clinician, oh no, everyone froze. Okay, so if I'm a clinician and a person of a sexual minority comes to me with OCD, how would I know that there's a connection potentially between their sexual minority status and their OCD symptoms? Is it always relevant to address the fact that they are of a sexual minority, or is it sometimes, hey, we're just here to treat OCD? Like it seems really complicated in the real world to me.
Yeah, it is. And actually, Brian and Andreas and I wrote a book chapter on this where we talk exactly about this and how to approach assessment. I think the big thing is everything is a balance, right? So we don't want to go in with biases in either direction. We don't want to go in with a bias of like, oh, this queer person has OCD, so their OCD must be latched onto their queer identity, because that could be really invalidating for someone who's like, no, like I just have scrupulosity and it's got nothing to do with it. But then we also don't want to have this sort of blind spot where we're not looking for it or not asking about it. I think as part of the sort of downward arrow of like, here's the surface level symptom, and then we're going to sort of dig down to see what that underlying core fear is. That's where you can understand, not only what is the core fear, but where did that develop from, and sort of address that accordingly. So I just realized that I didn't answer the second half of your question before about justice-based ERP, but that's a sort of lens that we can take on ERP to make sure that we are not inadvertently reinforcing stereotypes about groups of people, like when someone has obsessions about their sexual orientation or gender identity, for example. And a big part of justice-based ERP, and really all of ERP, is digging down and getting at that core fear, and treating that how it should be treated. So if the core fear is trauma related, my argument is always like, well, we need to handle that differently. if it's sort of rooted in trauma, and same with if it's rooted in minority stress.
Okay.
I'll just add super briefly. I mean, this is like a big topic that we could talk about for a long time, but I think as like a quick snippet for clinicians, I think really approaching sort of identity and how it might be influencing OCD with curiosity is sort of like the way that I think about it. So potentially directly acknowledging with folks that like, hey, we know that like people in certain identity groups often experience discrimination and different types of stress. And that can sometimes influence their symptoms and kind of what they're struggling with. Like, does that resonate with you? You know, does that seem relevant to your experience? And just kind of like leaving the door open and like getting people thinking a little bit that like maybe some of the experiences they're having related to their identity could at times be related to their symptoms, and kind of taking it from there. So it's kind of like, as Caitlin said, there's not like a one size fits all sort of approach, but just like being curious and like kind of exploring that possibility with someone. And if they're like, nope, doesn't seem relevant, then like definitely that's not something to keep sort of like pushing and saying like, well, like there definitely is a connection because there have been these articles published.
And Andres, I'm going to task you. Caitlin mentioned this justice-focused treatment model. I hope you're the right person to answer this question. And she said, like, okay, you know, someone has sexual orientation obsessions. Maybe you don't want to reinforce stereotypes. I guess I'm struggling to see like exactly what that means in practice. So could you give me an example?
Yeah, I'm going to pull an example right from paper from Caitlin's paper.
Perfect.
But the idea is that and please, Caitlin, jump in, and Brian, correct me when, you know, if I make a mistake or say this wrong. But the way I'm thinking about it is like our exposures that we're setting up for folks with OCD should not perpetrate or maintain any stereotypes. And I think this is true. It's incredibly clear for sexual orientation, but it also, I think, cuts across other protected identities. So I'll give you like an example. You know, an individual who, let's say, identifies, this is historically how we've talked about it. I think there's nuance to it, but historically, like there's an individual who identifies as heterosexual, but they might have an obsession of like, what if I don't, you know, what if I'm gay or what if I'm bisexual? And so a therapist might say, okay, let's do an exposure then where you go up to somebody who, this is like, feels so problematic to say, but this is how it was being done and is being done, sadly, still sometimes, some places, is like go up to someone who looks like they're, you know, gay based off literally how they look or talk or something. Go to Andreas at the end of the hall. He sounds gay. And like spend 5 minutes with him and then walk back. And then like, we'll like assess how like basically that the exposure involves that other individual. And the idea is that is reinforcing so many stereotypes that A, you can know someone's identity based off looking at them. B, that they're a prop that can be used for your own you know, exposure. I think we can all understand pretty quickly how that could be problematic. So I think justice-based ERP, like Caitlin had previously said, is sort of like, well, the core fear, if we like really do a downward arrow, is probably something deeper than what if I'm gay? And it might be more, what if I never know who I really am? What if my identity is something that like I don't have a good grasp on it and I never will? And if that's the case, then we can design exposures that are more based around like uncertainty. So we don't have to use anyone as props or rely on any stereotypes. And we could maybe have them engage with that in a different way. Like, can they hold a pride flag? Can they attend a pride event that explicitly involves allies? So we're kind of shifting it in two ways. One, we're trying to get at like the deeper meaning of what is the core belief around that specific symptom. And how can we engage with that exposure in like a justice-informed, responsible way?
So the justice-informed lens really isn't specifically for folks of a sexual minority. It could be a heterosexual person who has sexual obsessions, and then you just don't design an exposure that's very problematic for a whole number of reasons. Seems reasonable enough.
Yeah, definitely. It applies across the board.
I want to also say that I don't think it's like for people who have been doing that, it's not like intentional. I don't think they're trying to perpetrate stereotypes for the majority of the time. I try to have like, I feel like a lot of grace and empathy that people were trained in different ways by different people. And so it's not a judgment, but it's like, hey, let's redirect and let's do what we think will be most helpful. And again, that's Caitlin's words out of Andreas's mouth.
Yeah.
Well said.
That's a good point. We just got a text from the back end that we should wrap up, and I agree, although I have more questions about justice for treatment. But because we've talked a lot about like statistics, individual papers, I feel like this live stream, more than a lot of the other ones I've done, have been like very heavy in the research, which I like. But if you're not a researcher, maybe it's been confusing at times. So I kind of want to go around and just everyone say, like, if you are a person who is of a sexual minority, who's in a sexual minority and listening, or you're a clinician who wants to take something out of it, what's like a takeaway you want someone to take from this live stream? And I'll start with you, Caitlin.
I think the takeaway I would want you to glean from this is that there are these important nuances and intersections with identity and minority stress that can impact OCD in ways that you won't necessarily know unless you ask about.
And what about you, Brian?
I guess since I said a little bit about sort of clinicians, I'll sort of add for like people who are out there who are LGBTQ in some way and living with OCD or related disorder, maybe be curious about like how your own experiences related to your identity may or may not influence your symptoms. And if you are noticing anything where you're noticing for you some sorts of connections between these, hopefully you feel comfortable with your provider and sharing this sort of information and kind of working through it. Or if not, hopefully you're able to find a provider who is affirming of your identity where you are able to do that.
Mm-hmm. And Andres?
I'll just say from like a research perspective, this is like a really, really challenging time to be studying the intersection between, you know, LGBTQ identity and OCD, but that our work is important and that hopefully we will continue to pursue it. And just like being open and curious, and let's see what the data tells us.
Yeah, it's funny you say that. My dad, when I told him that this was the topic of the stream, he was like, "Oh, it's an interesting time to be doing that topic." And in my head, I was like, "Nah, it's the right time though." Like, yeah. We got to keep talking about these things. So thank you all for joining and answering my really nitpicky questions. For everyone on the stream, thanks for hanging in Sorry, I'm reading the back screen message. Thanks for hanging in with all the research talk. If you're not already signed up and if you want to go to the conference in July, there is the IOCDF conference in July, on July, I think, like 8th through the 11th, 8th through 10th in Chicago. I'll be there. I don't know if all the panelists will be there. Give thumbs up if you will. All right, we got one. So you can hang out with me and Caitlin. But yeah, thank you all for joining. Thank you to my panelists for joining, and everyone have a good day.
Thank you so much.
Pride, everybody.
Happy Pride.